We have a lot of changes in our practice, and the moderators will be Dr. Massimiliano Visocci and Manas Kumar Panigrahi. I will let the moderators to continue that session. We have 1.5 hour duration, and then after that, we will start a very special conference by Dr. Robert Spetzler.
Yeah. Good evening. Will you start, Dr. Massimiliano, introduce something? Today we have a common topic of spinal metastasis. I request Dr. Massimiliano to tell a few points, and then we'll start the meeting. Can you hear me, Doctor?
Massimiliano, you are unmuted. You can speak.
Just to introduce this very interesting lesson, I think that there are many topics to be clarified: indication, surgical strategy, and prognosis. And according to the indication, is it always indicated to operate spine metastasis, which are the requisites and the clinical and radiological pattern to go on? And moreover, what kind of percentage of effective treatment does exist in neurosurgical momentarily? I think that this should be the topics that we have to consider. And please, I'm looking forward and can't wait to hear our speakers. Please, my colleague.
Yeah, it's a very difficult topic because the most important is to decide to treat or not, and if you treat, whether first go for surgery or go for radiation, and if you go for surgery followed by radiation, what should be the time interval between radiation and surgery. So what we learned today is all these controversies, when to treat and how to treat, and how long to treat. With these few words, I'll request Dr. Newman to start up on speaking on decision making of a patient with spinal metastasis. Dr. Newman, can you please share your screen?
Okay. Can you see my screen now?
Yeah, yes.
Perfect. So good morning and thanks for having me. I'm going to be touching on classification, decision making, and metastatic spine disease. And as you said, I'm Chris Newman. I'm from Memorial Sloan Kettering Cancer Center, and this is the majority of my practice is really dealing with this. So looking forward to this talk and really appreciate the invitation. I have no relevant disclosures. So really this talk is going to be a talk in two parts, predominantly on this first half, which is decision-making frameworks, which will really delve into how we make decisions, but also a little bit of how we classify these tumors and how we look at that. It's a global way of looking at this practice and management of spinal metastatic disease, and then ending with a quick case presentation just to highlight, what this looks like in real time. And so here at Sloan Kettering, the framework that we use is the NOMS framework: N for neurologic, O for oncologic, M for mechanical with respect to stability of the spine, and S for systemic disease burden, but also how well the patient's doing. And I'll walk through each of these elements, but it's not to say that NOMS is the only decision-making framework. There is LMNOP, there is MOS, there is a alphabet soup of different ways that you can actually approach this, but it really is saying having an actual systematized way of looking at this problem is what you want. And for us, NOMS is what does that. And we appreciate the flexibility that it gives us. And so if we start looking into what NOMS is, we can start with the neurologic portion of NOMS, or the N that's there. And so the N really gets to a combination of the radiographic appearance of the actual tumor and how much is compressing the spinal cord, as well as the neurologic examination with questions of myelopathy or radiculopathy coming into the picture. picture when you start thinking about this. But as MRI has gotten so much better, really the radiographic correlates with the physical exam findings. And so when we think about epidural spinal cord compression grading, or Bilski scoring, as it's sometimes known, the grade 2s and the 3s that you can see highlighted in figures B and images B and C down here are where you're actually having compression of the spinal cord with or without residual CSF visible. And in this category of folks, we'd say, unless a tumor is highly radiosensitive, and we'll talk about what radiosensitivity means in subsequent slides, we talk about surgical decompression to try to create a target that is actually amenable to an ablative dose of radiation while sparing the spinal cord an actual toxic dose of radiation. On the other half of this, when we have these 0 to 1 Cs, right? So all the way up to epidural spinal cord compression that's abutting but not displacing the spinal cord, radiation can be considered as initial treatment, but in that 1C range, not all 1Cs are the same, and discussion with the radiation oncologist becomes helpful in terms of what's needed in terms of making space around this. And I'll show a little bit of radiation data that underpins our neurologic kind of assessment of these things. If we switch over to the oncologic portion of the assessment, this is really, I think, the part that's really evolving currently. And I'll show some later slides and data about this, but when we think about the oncologic portion of NOM, it really is asking, what is the responsiveness of a tumor to the currently available treatment? And that includes both systemic treatment options as well as radiation treatment options. We tend to focus on radiation because it's minimally invasive, it's highly effective, and it gives us good durable local tumor control, which we'll talk about in subsequent slides. But it's also historically systemic therapy options have not had good penetration into the epidural space. That is changing, and I'll show some stuff on that later, but this is why we really do focus from the oncologic assessment about radiosensitivity. And so we break this down to kind of 3 groups of, are you radiosensitive, are you radioresistant, or are you somewhere in between those two? And so on the radiosensitive side, it's the lymphomas, seminomas, myelomas, the hematologic malignancies are the really exquisitely radiosensitive tumors. And it matters because they respond so well even to conventional external beam radiation therapy. Versus the radioresistant pathologies like the renal cells, the hepatocellular carcinomas, the GI tumors, even the non-small cell lung cancer, which is the one that we see a ton of. Like, those are the ones that need a higher ablative dose of radiation to get good, durable local control. And then you have things that are in the middle, like breast and prostate, where conventional external beam does actually have penetration and can get good results. Taking into context Saber Comet, PISA trials, things like that, that also show a role for ablative dosing SBRT in the oligometastatic population. But this is really a big workhorse of the NOMS paradigm of thinking about this, because radiosensitivity really does tell you what you need to do in terms of being able to get control of that actual tumor. And as a great example of this, when we think about those lymphomas and those multiple myelomas that are very exquisitely radiation sensitive, even if we have that kind of grade 2, grade 3 compression, these are people where, because it's so exquisitely radiation sensitive, even in the presence of that high-grade metastatic epidural spinal cord compression, we can consider emergent radiation. And here what we'll do is, when these people come in with an image like you see on the right side of the screen with high-grade epidural spinal cord compression, but either asymptomatic or subtly symptomatic, we'll put them on high-dose steroids, put them into a neuro ICU, serial neurochecks, and give them expedited radiation treatment same day or next morning. And we get those people through it without ever needing a surgery. And so I think that's why it's important to have this understanding of the radiation responsiveness, because it really does impact what your actual surgical treatment should and can be. The M part of the NOMS paradigm really looks at mechanical stability. And from this end, we use the spinal instability neoplastic score, or the SIN score. And you can see that score tabulated on the right side, and I'll walk through it. But the general nature of this is that lower scores, especially in the 0 to 6 range, are things that are stable, don't require surgical stabilization. Things that are in that 13 to 18 point range are highly unstable and require stabilization to restore that stability and help alleviate the pain associated with it. And the 7 to 12 range is this kind of indeterminate range that needs surgical assessment, or assessment by neurosurgeons to really figure out what do they need, neurosurgeons or orthopedic surgeons, to figure out what they really need. And the higher your SIN score is, the more likely you are to have severe pain. And the reason that mechanical stands on its own is because mechanical stability is something that radiation cannot fix. It cannot improve the pain associated with mechanical instability. And so it sits as its own separate indication for surgery to actually help alleviate and palliate the symptoms of the patient. If we look at the right side in the actual table outlining what all the parts of the SIN score are, it makes intuitive sense, right? If you look at the location segment, things that are junctional, so they're more mobile and have less additional support, like they don't have ribs there, they're not rigid, are going to be more likely to be unstable when there are lesions there, as opposed to when they're in the sacrum or the semi-rigid spine. If a patient has mechanical pain, they're more likely to be mechanically unstable, kind of goes without saying, than someone who has a pain-free lesion or even a biological pain, so kind of that diurnal variation of pain. And someone who's got a lytic lesion, that's going to be more destructive to the actual underlying bony structure and more likely to be mechanically unstable than someone who has blastic lesion, who is actually depositing bone, like in prostate cancer. And the same thing goes with alignment. Kyphosis or subluxation is going to be more unstable than someone who has normal alignment. And with vertebral body collapse, it's the more that you have of that, right? If you have lost 50% of your vertebral body, the more likely you are to have mechanical instability. And these are all things that kind of intuitively make sense to us as surgeons, but I think it's nice to have a systematized way of looking at it, especially when training people how to look and assess the spine. And so then we get over to the systemic side of things, right? So we've gone through the neurologic, the oncologic, and the metastatic, and those all have their own reasons and indications for doing surgery. But the systemic assessment is actually the thing that can rule someone out, right? If the systemic tries to look at a person's overall medical picture, their age, their Karnofsky score, their comorbidities, what their actual overall picture of their health is, and tries to ask the question of, even if the N, the O, and the M recommend a certain course of action, if we look at them as a whole person, is that the best course of action? And where you see that is in someone who has high-grade epidural spinal cord compression, a radio-resistant tumor, and you'd say this person needs surgery, but you may then say, but they're extremely debilitated, they're highly frail, their life expectancy is maybe 3 months. Should we put them through a surgery or give them a palliative dose of radiation? The systemic actually would tell you, if they're really sick, we shouldn't put them through something that has a 3-month recovery period because they're not going to live long enough to get the benefit out of that. Now, the hard part here is that there's tons and an abundance of data that says that we as physicians over and underestimate the actual survival of patients, and we're terrible at prognosticating this. And to that end, multiple different algorithms have been developed to help us better do this. And to give it one example of this, you can look at the Sorg nomogram, which was validated out of Mass General, and it tried to take in the ECOG status, what your previous systemic therapy was, other comorbidities, your hemoglobin, all these different factors that make up a patient, and then put them all together and then churn out an actual score to say the probability of someone's 90-day and 1-year survival is X. And I'm a firm believer that this score, this percentage, isn't the end-all be-all, but it helps to drive a conversation if you can hang your hat on something and say, to some degree, you have a lower likelihood of being alive at 90 days. Maybe we should do something smaller for you. Versus if someone is 90% chance that they're going to be alive, it shifts how you may view the intervention or option that you choose for them. You may be willing to be slightly more aggressive because there is a longer term survival benefit there. But like anything, it's a tool. It is not the end all be all. It shouldn't be viewed in a vacuum as a decision-making criteria or something that is an exclusionary criteria in a vacuum. And it's just a part of the actual overall conversation with the patient. Now, so we've gone through the N, the O, the M, and the S, but underlying it all, when we talk about radiation and radiosensitivity as part of the O, we're really intrinsically implying radiation has good control. So I always think it's worth showing the data on what that looks like. When we look at SBRT dosing, what we see in essentially people who are getting just radiation, no surgery, high dose SBRT here. This is a retrospective review from Sloan Kettering, 811 lesions, 657 patients over a 12-year span of time with SRS as a first-line therapy. We were able to get 2-year local control rates of 98%. But when we look at it from the standpoint of separation surgery, so really doing laminectomy, bilateral pediculectomies, reaching around the front and then instrumenting these people, following that with FBRT, we also have data that shows good 2-year local control, even in the radio-resistant histology. So when we look at something like renal cell carcinoma, which if you recall the oncologic slide, was listed out as being one of the more radio-resistant pathologies, we're still seeing 2-year local control rates that are approaching 92% in this group, right? And this is with high-dose hypofractionated as well as some single-fraction SRS in this group, the majority getting those high-dose those treatments. If we switch over and we actually look at the same paradigm in non-small cell lung cancer undergoing hybrid therapy, and keep in mind, it's 2012 to 2019, so some of this may even be better with newer agents that are actually popping out and onto the market. What you're seeing here is a 2-year local control rate that almost approaches 95%. And when we look at the actual treatment plans, you see most of these people are getting high-dose hypofractionated radiation. So 30 gray and 3 fractions or 24 gray and 3 fractions. Doses along those lines is the bulk of what people are getting here. But if we actually look at colorectal cancer, this is where it starts to get interesting. It's a little bit of a harder to control histology, where we're seeing the 2-year local control rates, even though it is a small retrospective group of just 50 patients over this span of time, having about an 86% rate of local control at the 2-year mark. So not as good as what we're seeing with the renal cells, what we're seeing with the non-small cell lung cancers. And so to this end, I think this gets to the idea of how we actually define that O, or that oncologic portion of the radioresistance. When we start talking about that, we actually did a retrospective review, and this is unpublished data courtesy of one of my radiation oncology partners, Dan Higginson. And what he and his group did is they did a retrospective review of 1,842 patients who were treated to 2,700 lesions with spine SBRT from 2014 to 2023. And they used a recursive partitioning analysis to look at their actual outcomes and figure out, can we use that to classify radiosensitive, intermediate, and radioresistant histologies different than what we were doing in the previous paper that I showed under the oncologic subheader before. And what they saw was actually pretty interesting in that when you look at this radiosensitive category of breast, prostate, and thymic, their 2-year local control rates are about an average of 8.5%. You look at the intermediate category of the non-small cell lung cancers, melanomas, thyroids, renal cell carcinomas, they border around about 13% for their 2-year local control rates. But in this new radioresistant category, which predominantly, if you look at these pathologies, colorectal, esophageal, hepatocellular, pancreatic, cholangiocarcinoma, GI malignancies, there actually are really bad actors. These are the ones where we're seeing, even with SBRT, 20% failure rates or local failure rates at the actual 2-year mark. And I think this goes to say that not all tumors respond to SBRT the same. And so with that in mind, where this is a group of bad behaviors who we can truly say are radioresistant, and something that we've actually shifted in our practices where we were starting to treat grade 2 to a lot more upfront SBRT. If you're a grade 2, but you fall into this GI malignancy category, we're really going aggressively after that epidural space to try to get you the best dose possible of treatment, because we know that in this category, it really matters. Whereas in this intermediate category, we're still getting good results of, 13% 2-year local, 13% local failure rates at 2 years, but we'll still be very aggressive in this newly defined radioresistant category. And I alluded to this earlier when I talked about the oncologic segment being really focused on the radiation arm of it in terms of how we define responsive to available treatments. But I think something we have to pay attention to is the fact that we are getting better systemic options. And so this is a patient who was an EGFR mutated, ALK mutated, PD-L1 mutated lung cancer patient who initially with an unknown diagnosis, we took her to surgery, did a separation surgery. You can see that she had high-grade epidural spinal cord compression at the index level here, but she also had sites of epidural disease that were 1Bs and 1Cs at other levels. We did a separation surgery for her, and you can see here, 2 above, 2 below construct, decompressed her, but we actually didn't treat her with radiation. We put her on a novel agent, and what you can see is at 1 year, we actually had response both in the epidural space and the bony disease at the index level, as well as the levels above and below, which is a game changer, because historically you would think of epidural disease as something that required radiation treatment, but there is emerging data that there is penetrance into the epidural space with some of these novel agents. But the caution here is that we don't know who is going to respond, who is going to have a quick response versus a durable long-term response. And if you look just 3 months later, this patient had progression of their disease and wound up getting radiation to the areas that we hadn't treated before. So this is not to say that we're in an era yet where we can hang our hats on systemic therapies as having epidural penetration and being the workhorse where radiation has been for all this time, but it's saying the field is shifting, the field is evolving of kind of medical oncology, and we have to pay attention because at some point we may be using certain agents in combination with surgery or even before surgery to actually treat patients. But this is kind of emerging stuff, but I think it's worth noting and highlighting. And so if we try to summarize all that information of how do we think about gnomes and how does that work, and I love this slide from my partner, Mark Bilski, and it's really saying, look, in people who have a radiosensitive tumor, but either high-grade or low-grade epidural spinal cord compression with or without myelopathy, get them the conventional external beam if you can. If you can get it done expeditiously, this is what we tend to do. If you don't have that option, you do surgery, you get them out of trouble, you keep the patient safe. But if you're resourced enough and you can get them to expeditious conventional radiation, it will melt away, it will get better, as we talked about earlier. In people who have radio-resistant tumors with low-grade epidural spinal cord compression, so those 0s, 1As, 1Bs, and some of the 1Cs, we'll take them straight to SBRT because we know that an ablative dose for most of those pathologies will work well. And that's the data that we showed. In the group where they have high-grade epidural spinal cord compression with or without myelopathy and a radio-resistant pathology, or they've been previously irradiated, right? So re-irradiation is needed. We talked about the failure rates. We will take them to separation surgery, and then we'll take them to either SBRT or stereotactic radiosurgery, depending on what the actual imaging looks like post. And then mechanical instability is its own separate indication, right? So if you're mechanically unstable, stabilization surgery makes sense. You do it, you actually alleviate the pain, and that's something I think we've all experienced in the scene. And then the systemic part of this, right? If they're able to tolerate surgery, you take them to separation surgery, and then you can take them to their radiation afterwards. But if they can't tolerate the surgery, they can't tolerate your proposed intervention, you got to think about getting them to radiation to palliate their symptoms, because putting someone through a large surgery that they're not going to have time to recover from isn't doing them any favors, when the goal of much of what we're doing surgically is palliation or getting them onto a definitive therapy. And so if I can do a quick case presentation just to show what this looks like in action, this would be a 57-year-old woman with metastatic leiomyosarcoma, new spine metastases, so kind of first presentation of spine mets. Neurologically, she's myelopathic, but she's full strength. You can see that she's got high-grade epidural spinal cord compression on the axial images, the T2 and on the T1 post-contrasted. From an oncologic standpoint, leiomyosarcoma is radio-resistant, so we know it's not going to be one of those where we can take it on to conventional external beam and try to treat it like if this was a myeloma or something along those lines. From a mechanical standpoint, no mechanical pain. And from a systemic standpoint, she's relatively healthy. The KPS is 90. Disease has been controlled other than this new metastasis, and she's been controlled for about a year. And so this is someone where we would say, look, this is someone who needs a separation surgery to create a target for definitive radiation or an ablative dose of radiation. So we would take her to the operating room. And here we've been doing a lot more short segment surgery. So we do a screw above, so T8 to T10, separation surgery. So rods and screws drilling out the pedicles bilaterally, as well as a laminectomy. You can see what that looks like on the postoperative lateral x-ray, but you can also see we get a lot of postoperative myelograms. You get reconstitution of the thecal sac in the actual area, accounting for a little bit of postoperative hematoma that can always be in the actual cavity. And intraoperatively, we always get an intraoperative ultrasound and look, and you can see the quality of your decompression, where here what you can see is spinal cord in the middle with the red asterisk around it, but then thecal sac here with the CSF and full pulsations there. And on a lateral view, you can see just how free that cord is now compared to what it was before. And I always think it's worth saying and highlighting that when we talk about separation surgery, it's not just a laminectomy. It really is laminectomy plus drilling the bilateral pedicle to be able to reach into the ventral epidural space, cut the PLL, access the ventral tumor, and really do a thorough decompression, including sometimes taking a little bit of the vertebral body out to actually get the good decompression. And when we look at what that looks like, 2 years later, she's doing well, absent perfusion at the index level, has good disease control. And so I think this is how we think about this fitting into this paradigm of really taking the N, the O, the M, and the S and factoring it into how we treat the patient. So with the last slide, what I'll say, just a couple of conclusions, that the use of these decision-making frameworks really helps to systematize decision-making in spine oncology. And it doesn't matter which of these decision-making frameworks you're using. Like, we love GNOMES, we think it's the best, but there are lots of options around. And as long as that framework gives you the flexibility to account for new therapies, novel things in the way the medical oncology field is evolving, it's going to work for you. Just have a way of formalizing your thinking. Help all of us. The area of SBRT spine mets, their local control is still histology dependent, right? The GI cancers act worse than some of the other ones. That's just something that we have to be aware of. Patient prognostication tools are adjuncts, but they're not the ultimate decision maker. It really is a conversation, and it's the art of medicine. And as we get more and more novel systemic therapies, they're going to change what our indications look like, both for operative indications and our radiation indications. And I think that's where things are heading. So with that, I will stop and I'll say thank you for your time.
Very good. Congratulations for your beautiful presentation. I think that it was a great, huge overview of all up-to-date in order to manage this challenging topic. I've enjoyed so much all your options for a complete treatment, but I didn't see any reference to embolization. What do you think about embolization, both on the pain killing and surgical decompression and oncologic reduction profile?
Yeah, so I mean, I think that's a great question. And actually, I have some data that's unpublished currently that's going to be coming out hopefully in the next few months. So if I think about last summer, the summer before, there was some data out of the Ohio State University group looking at whether or not preoperative embolization of tumors leads to better local control, better kind of overall survival. And they showed some benefit in that. We've done our own series where we looked at it a little bit more homogeneously because they have kind of an all-comers look of breast, prostates, lungs, kind of a mix of radiosensitive and radioresistant histologies in there. And for us, we've really traditionally used preoperative embolization, not for palliation of pain, but really when we think about pre-surgically going after reduction of blood loss and really looking at tumors like hepatocellular carcinoma, renal cell carcinoma, and some of the thyroids, like medullary thyroid, which tends to bleed a little bit much. And we really use it for kind of blood loss control. So we actually looked at our data, and we have a series of about 130 to 140 patients who over the same period of time either did or did not get preoperative embolization for those three histologies. And what we see is that we don't see any overall survival benefit. We do see a reduction in the actual amount of estimated blood loss during surgery. We don't see survival benefit, and we don't see local control benefit, which to some degree makes sense because if you're embolizing a tumor, you may actually be decreasing blood flow, which then actually may have some implications for how the tumor responds to radiation therapy. But also, you wouldn't intrinsically think that it would have an impact on overall survival as well. So what I'd say is, for us, we think about preoperative embolization from the standpoint of helping us with decreasing the blood loss in a patient who's already, got a lot going on from their cancer diagnosis standpoint. We don't lean on it as much from a pain palliation standpoint. We'll use more kyphoplasty. We'll use more radiation surgery to try to get control of the actual oncologic portion of that with, I think, good results. But we really use the embolization as a preoperative workhorse for those vascular tumors.
Thank you.
Yeah, can I ask a question? Yeah, means when one follows the NOMS protocol, how do you decide the survival? Means it has been difficult to decide because the whole decision to treat or not depends on the survival of the patient.
Yeah.
So what do you follow? What protocol you follow to decide the survival?
So I know that I put it out there as a, plug it into the nomogram, see what comes out. But I think really what we lean on is this multidisciplinary conversation where we sometimes will use nomograms to help inform us. If we look at someone like they look really sick and medically we feel like they're sick, but the oncologist is saying, I think that they've got a, good long-term, we'll use the nomogram to help inform our actual conversation. But I think a lot of it really does boil down to having these talks with our medical oncologists about what the options are. And so I had a woman the other day who, if you plug her into one of these nomograms, it'll tell you 10% of likely survival. And she's running out of options X, Y, and Z, but she's high grade compression, grade 3, and becoming slightly myelopathic. And even the oncologist say yeah, she doesn't have good options. But then part of the conversation around survival is we've got this new targeted CAR T cell therapy that if we try it, 10% chance she's totally cured and it's all done versus 90% chance that doesn't work and then she goes on to die from it. So I think even with nomograms and other things, it's a conversation with the medical oncologist about what options do you have? What does that look like? And when we think about the way that we do our surgery, we've gone to doing these shorter segment surgeries because when you can keep the blood loss under 300 milliliters and when you can get them in and out of surgery in 2.5 hours, they tolerate it well enough to where it seems like it's an okay risk to take for them. But it's a conversation with the medical oncologists who really have known them throughout their entire cancer diagnosis, really understand what their options are. And then we bring in the radiation oncologist because sometimes we'll say, yeah, it's a grade 2, but it's a kind of grade 2 where we can hit it with an ablative dose and that's the best option for them to keep them on therapy. So there's not really a great answer, but it's this multidisciplinary conversation that lets us try to be as good as we can about it until we start using AI better to really understand all the different risk factors that are in the patient's chart.
Yeah, thank you, Professor Newman. And I think because we are short of time, and I'll request Professor Angelo to educate us on the role of radiosurgery in spinal metastasis.
Can you hear me? Everybody's frozen. Can you hear me? Can you see my screen?
Yes, we can see.
Um, Thank you to Mehmet for the very kind invitation to participate this morning. Thank you to the organizing committee. It's a real privilege to present to this group on spine radiosurgery indications and techniques. So spine metastases, as you've been hearing, is a very important direction that we're going overall in the oncologic care of patients, because we know now that the systemic disease progression, rather than the spinal mets, typically determine the patient's overall life expectancy. So any intervention that we do that's effective and has a minimal global effect on the patient, not long recovery time before they can continue with their systemic therapy, are all extremely valuable and desired treatment options. So a multidisciplinary integrative therapies are essential. And now we're starting to move more to treating not just those patients that are symptomatic, but we're starting to think about the asymptomatic spine metastases patients, because patient prognosis is prolonged. And by interceding at the asymptomatic phase in many of these patients, we can prolong overall survival. What are the important treatment goals in terms of spine metastases? We want to preserve and restore ambulation, maintain bladder control, relieve pain, and all of that is essential in patient quality of life. So the 21st century has essentially ushered in the new era of addressing spine metastases. The first game changer, things that changed how we look at this problem, things that moved the needle, if you will, was the study by Patchell, which is now over 20 years old, more than 2 decades old, where we learned that direct decompression by surgical resection in the treatment of the spinal cord compression improves overall patient survival and many other factors by doing surgery plus conventional radiation instead of just conventional radiation alone. Because until that point, we as surgeons were blocked out a lot of this management of spine tumor care. So what we learned based on this randomized control study is that patients retained their ambulation rate, regained their ambulation rate in those that weren't walking, their neurological exam improved, their survival improved, their analgesic use dropped, their corticosteroid use dropped, all of which contributed to superior outcomes, and the study was stopped early. So all of a sudden, we as neurosurgeons and as spine surgeons, orthopedic and neuro, we were on the forefront of managing these patients and involved in the early discussions and decisions. Sorry, my mouse seems to be quite touchy this morning. So fine, surgical limitations achieve tumor, can achieve local tumor control, but it doesn't work. I heard Chris talk about the fact that there are some more radio-resistant pathologies, and we concur. We've known this for a while in terms of the intracranial radiosurgery targets, with colorectal cancer brain metastases being much harder to control with radiosurgery than other tumors, including renal. But still, while surgery improves neurological recovery and stabilizes the spine, metastatic tumors are not resectable to cure. So we must not throw the baby out with the bathwater, saying that radiosurgery doesn't work with colorectal cancer. And Chris, I know that's not what you implied, but just to be mindful, because when people hear, oh, it doesn't work for that indication, the thinking is, oh, well, we shouldn't be doing it in that indication. But we must remember that conventional radiation works even less for those radio-resistant pathologies, and surgery doesn't give us very durable control, no matter what we do in this setting. So we have the second game changer, decompressive surgery, and followed by spine radiosurgery. And most of you in this room are quite familiar with spine radiosurgery. It is targeted radiation delivered in a accurate and conformal way. In this illustration, you see the tumor outlined in the pink line. You see the orange is the radiation targeted dose with a very steep fall-off dose adjacent to the spinal cord. So the analogy is it's like a glove fitting a hand. So it is very tight to the target, but drops off very quickly, and you can move the fingers or get objects away from it. The dose drops nearly 20% per millimeter. So, and in this manner, we can deliver more than twice the amount of radiation to the tumor that we can with conventional radiation. But again, as Chris alluded to, and as many of us that have been in the field a long time are very aware, It's a multidisciplinary treatment, and it requires multidisciplinary approaches to make this safe and effective. Who do we treat with spine radiosurgery? Patients with pain or tumor progression. Both of those indications are very strongly controlled with spine radiosurgery. Those that have minimal to moderate spinal cord compromise, those that are previously irradiated. In conventional radiation, if you give 30 gray and 10 treatments, the next time the cord won't tolerate that much. So the next time with conventional treatment, you have to give less. If the first higher dose didn't work, conventional radiation isn't going to work as a second dose treatment. So these patients were getting a second dose treatment before spine radiosurgery came along, and then going nowhere and going to hospice because they could not ambulate and they do not have a high enough performance status to get further systemic therapy. So in some indirect way, this was life-limiting until we could do very targeted irradiation with radiosurgery. Those that have residual recurrence after surgical therapy, this is very much separation surgery paradigm. Those that we couldn't get at very easily to decompress, those that have very short life expectancy from their metastases, and those that have significant comorbidities that we can't get them to surgery. All of those indications you heard alluded to in the notes. Who do we not treat with spine radiosurgery? This is an important portion as well. Those that have rapidly progressive neurological deficit. I had, in my early days, treated a patient with multiple myeloma, a very targeted recurrence. However, even though this is extremely radiosensitive, the patient deteriorated before we were able to deliver the treatment, which we had ready within 4 days. But the patient, by the time we brought them down for treatment, had lost all power in his lower extremities and had to be taken for emergent surgery. So this is not the treatment for patients that are rapidly neurologically declining, nor is it the treatment for patients that have cord compression with bone or disc fragments. Obviously, radiation doesn't work on those indications. And those with no known tissue diagnosis for cancer also are not appropriate for this treatment, such as you don't want to irradiate a patient that has an infection. Moreover, those with overt spine instability, no amount of radiation will treat spine instability, and therefore we have to treat this in a multidisciplinary fashion. So we have to be mindful that just because we have a hammer, not everything is a nail in terms of this indication. This is an older slide that looks at series for local control with radiosurgical treatment, larger series, and you see that the control rate is anywhere shown here between 70 and 95 beyond %. So highly effective treatment. Not a lot of cancer treatments that we can tell patients. We can control your local problem at about 85 to 90% of the time. This is a huge change in terms of cancer discussions with patients. We can control your pain 85 to 90% of the time. And this slide gets at that. With spine radiosurgery, their own prospective work, we found that as early as 1 week, we have statistically improved pain relief using the BPI pain score, and it's durable at 9 months out. And this can be with as little as treating a single vertebral level. We improve the patient's pain score globally. We improve things like their insomnia. We improve their constipation because they don't have opioids and therefore they don't have constipation. And we found that in these patients, their narcotic use dropped and their no pain medication rates increased. And overall, we had a durable quality of life for the patients in our series. Now, for those of you that haven't seen spine radiosurgery, this is a patient's journey. This is one of my patients that you see the therapists are putting him on the table, comes in. This is one of my radiation oncology partners who we've done an enormous amount of work together. My patient allowed us to take these images. He is being lined up. We have a mask to immobilize him because you can't target your target if it's moving. You can't effectively do submillimetric precision. The target is moving. We have open face mask because where there's facial recognition and recognition. There are patients that are claustrophobic for the treatment. They lay down. You can see the marking of the mid-cervical spine where we are targeting this patient. He is lined up for treatment. He's very relaxed. He's comfortable. And at 5.5 minutes, he is coming off the table and going to lunch with his wife. I'm a surgeon. I love being in the OR, but there is no better outcome for a patient than to get off the table and go on to proceed with life and their families, especially when they're fighting so many battles with cancer globally. So this treatment is a very rewarding practice to be involved with, especially when the rates are effective to 85 to 90%. So what are the major potential benefits of radiosurgery? Short treatment time in an outpatient setting, no recovery time, good symptomatic response, positive impact on quality of life, successful tumor control, low morbidity, minimal risk of radiation myelopathy. The studies indicate that the rate of radiation myelopathy is less than 1%, 0.6 or 6 per thousand, essentially, and particularly relevant for tumors that are conventionally resistant to radiotherapy, such as melanoma, sarcoma, and renal carcinoma. Here's a case of a patient who had a C2 renal metastases. He developed severe neck pain with a lytic destruction of his C2 and a synchronous renal mass. The renal mass was biopsied and showed RCC, and one of my colleagues did posterior neck stabilization, but did not tackle the ventral disease. So he had persistent pathology ventrally. He underwent a treatment with radiosurgery, 18 gray, with a single fraction. In 2 years post-treatment, you can see in the bottom panel, the ENF panel, that he had significant spinal cord decompression. He continued asymptomatic for 2 years beyond. Actually, now he's 5 years. This is a much older slide. He had no further intervention at this level, and he's gone back to coaching small children playing soccer. So with this procedure, we have gotten two relatively minimally invasive approaches, or non-invasive radiosurgery has gotten him very durable control in contrast to a surgical procedure that could have been extremely morbid and not given us the same durable control. What was also alluded to was that dose matters. We want to get in as much dose as possible. The only problem is that unlike the lung or the kidney, where organelles are duplicated, so you can take out one kidney and have the patient's renal function still be essentially maintained, or you take out a segment of lung, you cannot disrupt the spinal cord. It is a serial functioning unit, and therefore radiation toxicity to the serial organ will cause major morbidity. And so the key to treatment safety is to get in that high dose, but carefully dose constraint the adjacent spinal cord. So enter the third game changer that was referred to as separation surgery. And I think most in this room are very familiar with separation surgery, but just to be totally clear, separation surgery is separation of the tumor from the dural sac, thereby decompressing the cord in order to reconstitute the spinal fluid space, the CSF. Tumor in the vertebral body and paraspinous region is not resected, typically, reducing surgical time, reducing blood loss, and reducing morbidity. So our patients are not in the ICU for prolonged periods of time with limited prognosis. Decompression provides a safe margin. The purpose is to get that safe margin to deliver cytotoxic or ablative dose to the tumor within the constraints of what the spinal cord tolerates. If millimeters can be gained from back of tumor to front of spinal cord, that is huge because the vast majority of metastases occur in the vertebral body and often abut that region. Stabilization, of course, depends on the degree of instability, but most times it is 2 levels above and 2 levels below, and anterior reconstruction is rarely required. So we've moved the paradigm that surgery is an adjunct to the definitive oncologic procedure of radiosurgery. Separation surgery, some of this data was discussed, and I'll move on in the interest of time. Another study that we looked at in terms of fusion rates. We used to do surgery followed by conventional radiation, and I think that's the paradigm in many centers. What I might argue, even in this small series of 15 patients, we found that patients that underwent radiosurgery following surgery did better in terms of fusion rate and fewer instrument construct failures, breakdowns, screw breakage, etc., than those that had conventional radiation. So now the structure at risk is the construct. So if we do more targeted radiation and we don't try and we try and keep the dose off where the fusion is meant to be, in our patients that are surviving longer, we are able to not have to fix their instrumentation. We're not having to go 5 years alive from their having to fix their instruments, which have failed over time. And this study showed from Memorial's group that their hardware revision rate is very low and in a large series. So once we're starting to do that, the hardware pattern of failure after separation surgery and many times after radiosurgery is very durable. This has led us to a rapid expansion of the use of spine radiosurgery. So over the 15-year span that we looked at an international survey of 12 high-volume centers, we are seeing much more utilization across centers. And what we're seeing, if you look, for example, at the gray line, which is renal cell, we are seeing over these are 5-year increments, we are seeing many more classically radio-resistant pathologies being sent for radiosurgery. So this remains a very relevant use of radiosurgery over conventional radiation. Where are we going in the future? This is the more novel part, the more interesting, newer direction for radiosurgery. So oligometastatic disease is 5 or so metastases in patients that have a diagnosed cancer. So it is considered low volume metastases or low burden metastases. So classic approaches to oligometastatic disease are based on identification of patients with local or local regional group tumors or patients with distant metastases. So this has led to the hypothesis that if a cancer can be controlled using local ablative things like surgery, for example, in colon cancer when they're doing metastatectomies of the liver, when they're doing in sarcoma metastatectomies of the lung, can we, instead of surgery, use radiosurgery within that same approach to ablate low volume metastases? And this prospective study showed that indeed we can. It is a ablative radiosurgery across a number of targets, not just spine targets. And we found that patients that underwent radiosurgery to oligometastatic targets had significantly longer progression-free survival, local control, as well as overall disease control, overall survival. So we are starting to do much more oligometastatic disease. And what we're finding is if we look carefully, we find that not only do we kill the tumor in that area, but we are seeing new bone laydown. The fatty marrow replaces the previous osseous metastases. So we are getting reconstitution in certain aspects of the bone. It's not as good as native bone, but it's certainly stronger than tumor mush in these areas. So we are also improving, in one sense, the spine health of the patient by doing local control as well as their overall survival. So the current recommendation is that radiosurgery is safe and effective with durable symptomatic response and control. It should be considered over conventional radiation therapy for the treatment of spine tumors in oligometastatic disease and in radio-resistant histology. And as experience grows, the use of radiosurgery as a post-operative adjuvant surgical resection less aggressive, with the expectation that radiosurgery will help control or maintain the residual disease. But again, a reminder that was alluded to is that spine tumor programs are inherently collaborative, and this is essential for the program to succeed. We have a spine tumor board which really anchors our decision making. We meet weekly, we have multidisciplinary attendees, we have individual recommendations with an integrated plan. Many times it's before the patient has been seen, so that at the first clinical visit, we for the integrated plan, we of a database. As you see, there is high surgery participation here, where the blue part of the pie is cases brought to tumor board from surgery, but not necessarily treated with surgery. And the COVID was one of the few positive things to COVID is this virtual visual conferencing, where during that time, we saw a huge bump up in participation in spine tumor board. And at this time, we've reviewed over 7,500 cases at our spine tumor board to date. This pie chart shows the kind of cases that are brought. And one of the important things is you see about 20% are non-tumor, and we have 2 dedicated neuroradiologists that attend our spine tumor board. So we have a subset of our neuroradiologists that participate within this tumor board, and they help also define some of these cases that shouldn't be biopsied, shouldn't be managed, that they're non-tumor, there's some kind of inflammation, etc. So spine tumor board has really informed so much of what we do in these cases. So what does the future of SRS look like? It clearly demonstrates clinical value. It's non-invasive, can be completed in an outpatient setting. So patients from the rural setting or far from treatment centers come in and can get treated in one day. The minimal disruption to their systemic therapy, so they don't have to stop their chemotherapy for a month post-surgery. This allows patients to resume their normal activity as quickly as possible. It decreases medication, increases the need for retreatment because the control is more durable, so that there's huge advantages for society, for the healthcare system, and importantly for the patient. Why is this important? My patient, she allows me to take her picture. She's a retired manufacturer worker and a grandmother. She's diagnosed with stage 4 non-small cell lung cancer. Her neck hurt so badly that brushing her hair or flipping it off her face became unmanageable, so that she cut off her long hair. She underwent spine radiosurgery to C1, C2 with complete pain relief, and her tumor was controlled 4 years ago. Her hair is now back to waist length. She is pain-free, faces her grandson, and travels to watch her youngest daughter play college softball. These are our patients who deserve our best in terms of care. Remember the patient, and I'd like to thank this awesome team that I have the privilege of working with in terms of spine radiosurgery. Thank you for your attention. Happy to take any questions.
Thank you very much, Dr. Angelo, for your beautiful presentation, which is rising up also some question and consideration. Since radiosurgery interact both with radiobiology and mechanical factors inside the metastatic location, my question is, what's your experience about interaction between radiosurgery and embolization, vertebroplasty, and previous other procedure changing the local structure of the bone and of the tumor as well? So probably embolization and glue, the cement and vertebroplasty could interact negatively with radiosurgery. What happened when you deliver radiosurgery to those subjects?
So in fact, there's no issue whatsoever. Patients can have bone augmentation with no difficulty in delivering the radiosurgery. We've done Monte Carlo calculations. If there is any change in dose, if there is any change related to the instrumentation, if there is any change related to the cement, there is no contraindication with that. Embolization, in terms of, just to get back at an earlier comment about pain relief, we have been a little bit underwhelmed in terms of pain relief with embolization. We use it for blood saving rather than pain amelioration. I have even used this in the setting of symptomatic hemangiomas that have epidural extension. And we sometimes try embolizing those because that's one of the forefront indications. And that doesn't give us good pain relief. The key, though, to radiosurgery is that the images that we treat on have to be in close proximity to when we deliver the treatment. So our treatment time between the fresh high definition MRI scan with no skips between slices for targeting radiosurgery and delivering the treatment is typically between, it can be as early as 4 days, it can be as long as 10 days, but I will not work off a stale MRI scan because the tumor is growing in the meantime. The tumor is changing. If you can't target your target well because it is moving or because it has changed in size, then you're not doing precision targeting. And unlike conventional radiation, which is forgiving in terms of size, this is not forgiving because there is such drop off in dose, so that it, in terms of precision targeting, it cannot be off an old target. But there is no contraindication. Protons and some of the standard screws and rods interact. Radiosurgery, because it is photons, we have done the calculations and the dosing within our physics department, and there is no contraindication. There used to be lots of fear when we started this. We started the program in 2006. We've done this a long time. We used to be very anxious about, are we getting the dose? Where, in terms of compression fractures, we see a compression fracture rate related to radiation. I agree, that's one of the side effects. I always tell my patients, yes, there is a compression fracture rate, let's say 10%, for example. If that's the biggest toxicity, if we can control cancer but take a 10% toxicity of compression fracture, we'll take it. We all have compression fractures as we shrink in height as we get older. So that part is, I will take that as a toxicity. If patients have lots of motion, we can do vertebral augmentation after radiosurgery with no negative impact. I always do get a biopsy though to make sure that the cells are dead.
Just a second and last question and clarification request. Is it possible to deliver adrotherapy with the same modalities of radiosurgery? Why not?
It just got muted. I'm sorry. You asked me, is it the same?
Is it possible to deliver adrotherapy with the same modality of radiosurgery? High doses, shorter time, and with the stereotactic modalities. Is it possible to drive this option with these typical characteristic of the technique you showed us in your beautiful presentation?
Typically, no. Sorry, the sound keeps coming in and out, but I think I got the question. The question is it possible to use standard machines to deliver precision therapy, to deliver radiosurgery? Is that correct?
Yes.
Okay, so no, the system has to be, it has to be a different system. The aperture for delivery, it has to be very different. And there is a number of machines that can do conventional radiation and radiosurgery, but it has to be specially able to do that. You can't, drive a truck on a Ferrari course.
Yeah, there are some questions in the chat.
Thank you.
There's some questions in the chat box. Can I ask them? Dr. Parekh has asked how many levels of metastasis you can give radiosurgery. What is the maximum number?
So thank you for the question. Actually, I'm excited to answer this question because we have a paper that is coming out very shortly. We have to be practical. This is local therapy, right? And so we want to treat local disease burden. If the patient has many, many, many levels, it's appropriate to do conventional treatment. But we have recently looked at, and so the short answer is usually 3 consecutive levels are appropriate, and it can be in 2 or 3 regions. We have recently looked at our control rate for larger tumors versus single level and found that the control rate is the same, so that radiobiology and control is not impacted by size.
So what I understand is 3 bodies, either adjacent or at separate level, you can give in one sitting.
You can give 3 times 2, right? C 3 to 6 and L2 and L5. They're treated as completely independent modalities, but 3 consecutive
Okay.
is the usual.
Thank
Is
you.
that your experience?
Yeah, it's something similar on our end, where we do essentially treat them as different isocenters, and so we'll do 3 or so consecutive bodies, and then think about cervical, thoracic. Like if there's a large gap, think of them as differently, and then we'll also kind of try to triage them based on what's symptomatic as well, right? And try to say something symptomatic, prioritize treating that over treating the asymptomatics, and prioritize the epidural disease treatment over the ones that don't have that. So yeah, a similar paradigm.
Does it make a difference in the outcome if you treat with MR LINAC or a CT-based LINAC radiosurgery?
It looks like not based on lung treatments. So I cannot tell you we do not use MR LINACs. But the targeting, we use the CT simulation and an MR. So we use both those data sources in order to target.
This is a question for Dr. Newman about any experience with RFA in oligometastasis along with separation surgery and outcome.
I'll say I don't have a lot of experience with that here, and I think that's really a byproduct of the fact that we have such a robust radiation oncology department. And I think that's really where we've been treating it. And because we have such good outcomes from that combination of like separation surgery followed by SBRT, we haven't gone as deep into the use of RFA. So I don't have a good answer we don't really use it, so I don't have a lot of experience in that area. And I don't know what the data would say in terms of the long-term benefit. And kind of the same way if I look at like the Saber Comet trial in terms of like the oligometastatic population, where you can see a benefit to the treatment of ablative dose radiation from the abscopal effect. I don't know what that looks like for the RFA population. It's a great question. I just don't know the answer.
So we do RFA at our center as therapy at recurrence. And again, because we have 3 interventional radiologists that participate in spine tumor board, and so they step up to get involved. They step up if there is sacral recurrence, etc. So but we don't have robust data on it. It is definitely doable. The problem with RFA is radiosurgery can give us this glove on a hand because we can specifically target. RFA is like a ball on a stick. You cannot change its shape extensively in order to fit your target of the vertebral body. So that one of my concerns about doing RFA up front when we have a different modality that can be precision targeted is not so much concern for the cord or things like that, but concern for ablating the entire tumor region. It may be good in the portion, but if it looks like a ball in your vertebral body, looks like a vertebral body, you're not covering a huge component of the active cancer cells in that area. That's my bias. We do use it. We do use it in failure when we are maximized, because when you have a therapy that controls 90% of tumors, that means 10% can fail. We use RF in those settings, but not as our first choice. Does that answer the question?
I think to that same end, I would think about Claudio Tatsui's data kind of with their use of laser interstitial thermal therapy for the spine, where when you look at it, he's really not using it as definitive treatment. He's using it as like adjunct to get to the next thing. So I think that's probably a great place to look for data in terms of the papers he's published on that.
Yes, agreed.
Yeah, thank you, Dr. Angelo and Dr. Newman. And though we have more questions, we'll take their surgery questions. We'll take it after the lecture by Dr. Corina on surgery indications and techniques. I request Professor Corina to share the screen, please.
Hello, good morning.
Good
Can you
morning.
hear me?
Yeah, we can see your screen.
And can you see my screen? Wonderful.
Yeah. Yes.
Okay, great. Well, I wanted to thank you very much, Dr. Panigrahi, and thank you, Dr. Zalali, for the opportunity to be with you this morning from California. and I was asked to speak about surgery for metastatic spine tumors, indications, and techniques. And I will say that the two prior speakers have done an amazing job of speaking about indications. So I've deleted some of my slides and I'll go through the indications very quickly. And then I'm very excited to focus on some of the fun parts of doing the surgery, which I know that many of us as spine surgeons really appreciate. Okay, so let me move forward here. So we talked about this very, very nicely already, but anytime a patient comes to me with a metastasis to the spine, I'd like to know what's the primary tumor, their extent of extraspinal disease, of course, their neurologic status, and if they have a deficit, how long has it been going on for? Days, weeks, months, or years? Because this is really important in terms of how I'm going to think about the acuity of the intervention that's needed for them. We've talked about the importance of spine stability measured with the SIN score. We've talked about the importance of the patient's prognosis and then their overall well-being for surgery, which you can assess with various measures, including Karnofsky scores and an assessment of their overall medical problems. We've already talked about radiosensitivity of tumors, and we know that some are very radiosensitive, medium radiosensitive, and usually more radioresistant. And there's obviously important nuances to that depending on the type of radiation. It's important for me if I'm considering operating on a patient to know whether the patient's had radiation to that area, what type and how much. That's particularly important because it's also going to tell me about, one, do they actually need surgery at this point? And two, what's the bone quality going to be like when we're going in there? So that's a really important thing as well. Dr. Newman did a wonderful job of sharing with us the details of the SIN score and the NOMS, which are an important part of my practice. And Dr. Angeloff has done a great job of talking about some of our treatment options that include CyberKnife fractionated radiotherapy. So what are our treatment options from a surgical perspective? Okay, we can consider large cancer operations, gross total resections, front back surgeries, but I would argue that especially in the realm of metastatic cancer to the spine, that's not really what we are supposed to do as surgeons, right? These patients have disease in many parts of in many parts of their body. This is not a curative surgery for them. So really the mainstay of our practice is decompression and or separation surgeries and stabilization surgeries. And we'll talk about the really fun ways that we get to do these types of surgeries. And I think really importantly, we talked about all of these different classification systems and what are the different factors that we consider when we're deciding on whether to operate on a patient. But the question is, given everything that's going on, their prognosis, their neurologic prognosis for recovery versus prognosis without surgery, what type of surgery we need to do to fix their problem. Does the patient even want surgery, right? That's an important question that I ask my resident if they're seeing the patient first. And then, of course, I ask the patient when I see them as well. So my principles take into account many of the ideas that have been shared with us already today. Consider the stability of the spine with the SIN score. Consider NOMS as an overarching framework, the age of the patient, but because we know that age is just a number, also their overall frailty and the goals of the patient. Even if it's in the middle of the night, I try to always have a direct conversation with that patient's oncologist. If it can't be their primary oncologist, at least whoever is covering for oncology in our hospital. And then my principle is to try to do for metastatic cancer to the spine, to do the least invasive surgery possible, especially in our increasingly elderly patient population. This includes navigated guided percutaneous fixation, cement augmentation, mini open decompressions and separation surgery, and I'll share examples and surgical techniques now. So this is an example of a patient who came to me with metastatic prostate cancer and a very acute neurologic deficit. He presented to our emergency department as a transfer from another hospital in the Bay Area, 77-year-old male, heart disease, known prostate cancer history with the prostatectomy and now rising PSA. He came in with 5 days of lower back pain and progressive lower extremity weakness, now unable to walk for the last 36 hours. He's full strength in his upper extremities, and you can see he's quite weak in his lower extremities. His right leg is 3 proximally, 4 in his quad, hamstring, and plantar flexion, and 2 dorsiflexion EHL. And his left lower extremity, he's 2 proximally and 4 minus distally. You can see here an MRI post-contrast that shows that he obviously has significant disease present in multiple thoracic vertebral bodies. And this disease is present ventrally, but then he obviously also has this epidural component that's more dorsal that's causing severe spinal cord compression and is likely the cause of his acute neurologic deficit. So this is a type of patient that I think is important for emergent surgery. And in particular, this can be done really nicely with minimally invasive technique using stealth navigation. And I'll kind of go through the process here. You see here I did 3 above and 3 below. This is a relatively old case. I think I'd probably favor 2 above, 2 below at this point. And first of all, why do I use navigation for these cases? Chris has alluded to the importance of it's important to get these patients in and out of the operating room as quickly as possible. It's also important to minimize the blood loss. We also obviously want to place our screws with the highest accuracy and the highest precision, because even in surgeons who have been doing this for decades, mistakes can happen. We have looked very carefully at screw accuracy placement rates when you go from conventional placement freehand to 2D fluoroscopy and 3D navigation. And you can see that across all areas of the spine, cervical, thoracic, and lumbar, we have an incredible increase in the accuracy of screw placement rates when we go from freehands to fluoroscopy and finally to 3D navigation. So I'd say this is the equivalent of going from using a compass, paper maps, which I did used to use back in the day, to now GPS. I don't think any of us would go to a new country with our phones and not use GPS to get around. In our own analysis of over 50,000 screws, we found that CT navigation had the highest accuracy. And so when I'm doing stealth navigation, in particular for a case like the one that I showed you, which is the mini open separation surgery, we'll walk you through the steps. So we position a patient on the radiolucent Jackson. So in the particular case of a mini open surgery, we'll do a midline incision through the skin, use the C-arm to approximate the levels that we're operating on. And then importantly, we do need to place a spinous process clamp. So if it's a large fusion in this case, I would put a spinous process clamp both at the superior aspect as well as the inferior aspect of the incision, especially when I'm thinking about the kyphosis of the thoracic spine. If it's a shorter construct, you could only need 1 spinous process clamp. After you do that, you bring in the O-arm and you perform an O-arm spin. So importantly here, we have not opened the fascia, so we're not getting into any bleeding yet. So these are relatively low blood loss surgeries. Once we've done the O-arm spin and we can transfer the navigation over, and now we're using our navigated instruments, you can see here, we bring up what I call the navigated chicken foot, and we use this to plan our stab fascial incisions on each side. Use the bovie to get down to bone. Then we use a navigated power drill to drill the screw trajectory. I still use K-wires, and the reason for use, even though there's many companies that have K-wireless techniques for placing in percutaneous screws. The reason is that I like feeling the, for me, it's a way that I can kind of blend the feel that I get with open surgery and feeling the medial lateral, the bottom of my pedicle with the navigated system. So I use a navigated cannulated tap over the K-wire, and then I place a navigated cannulated screw over the K-wire. I do perform an intraoperative O-arm spin in order to confirm screw placement. And I'll talk a little bit about how that also factors into my cement augmentation and why that's important. And then, so in this particular case with this prostate cancer patient, so keep in mind, we actually don't have the fascia open in the middle. We've just done the stab fascial incisions on the side in order to place the screws. So then depending on the surgery that I'm doing, we can do the fascial opening in the midline. You can do the extent of both the laminectomy. In this particular case, this patient really only needed a laminectomy. We didn't need to go and get into the pedicles and decompress ventrally based off of his particular cancer. But as Chris mentioned earlier, for some of these patients, they may have a significant component of ventral disease for some of our metastatic cancer patients. And so then you do really need to do that more extensive decompression. After doing the decompression, we'll place the rods with the MIS rod inserters. I always will check my rod length on a So usually we'll start with a lateral C-arm just because that's what's in, but I oftentimes have to go to an AP in order to double check and make sure that both rods are long enough. And then I do use a navigated Midas burr to decorticate the facet joints. And then I use that technique in order to inject DBX because I think it is really important. We're obviously doing these cases in order to instrument and fixate the spine. We also need to be considering that these patients are oftentimes going to be getting radiation afterwards, as has been discussed. And so they're oftentimes getting multiple types of systemic therapy. So we do really need to think about the fact that these patients may not be the best patients to actually fuse. So any tiny thing that we can do during surgery that's relatively easy, even here in an MIS case, this can be something that can potentially assist with that. There are obviously pearls and pitfalls to these MIS navigation techniques, but I do think that they're ideal for hybrid mini open separation tumor surgeries like this one. We talked about the fact that you can use 2 clamps and 2 stealth stations if you have longer constructs. It's really important to optimize your clamp placement so that it is very close to the area that you were working on so that you have the highest degree of accuracy with your navigation, but also that it's not interfering with your screw placement. Always telling the resident or fellow who's working with me, as well as our nursing staff, to not touch the clamp because then your navigation will be off. And you really can have your navigation off with a lot of soft tissue retraction and manipulations. So you need to be aware of this. And I know it's not so much of an issue with cancer patients because they don't tend to be as large, although I did recently have a metastatic breast cancer patient with acute neurodeficit and a BMI of nearly 50 that I was operating on. So, even though we say that MIS is great for larger patients, there still is a limit to the size of patients that you can operate on with MIS. And so take this patient in particular. If you're getting too deep, what you'll see is that your instruments with the little balls that need to be seen by the navigated tracker can actually be deep in the patient and get covered in blood each and every time. So it's not a foolproof method for all patients. Okay. This is another example of a patient, and this patient actually had metastatic thyroid cancer with many months of, not surprisingly, lower back pain. She also happened to be a Jehovah's Witness. So for those who are not aware, they don't accept blood products. And we had a very extensive conversation because, as we've spoken about earlier, thyroid cancer tends to be one of the most bloody types of surgeries. So in this particular case, given everything that was going on with her, I did not feel that it would be feasible for us to do any type of open surgery for her, okay? Nor necessarily given the fact that she refused Cell Saver and all these other products after, hours and hours of conversations, significant debulking either. But we were able to do an MIS stabilization as well as a small decompression with less than 200 cc's of EBL for her, which then set her up for further systemic therapy after that. So cement augmentation, which has been touched on earlier, I think is a great adjunct, and I have been using it increasingly in my tumor patients, especially those who are undergoing post-op radiation. I also use it in my non-tumor practice for osteoporotic patients. And so when I'm doing this, I place fenestrated screws. And so those cannulated screws that we place over the K wires are fenestrated. They have holes that are towards the distal end as well as at the very tip, of course. And so when I'm doing this, I'll obtain a CT scan. So for me, that's an intraoperative O-arm scan. And I'll use this to confirm that the screw is perfectly placed, okay? This is much more perfect than what we would just accept if we weren't doing fluoroscopy, okay? There can be absolutely no tiny bit of medial or lateral breach. That is actually less important than looking at anterior vertebral body violation because these holes come at the distal end of the screw. So sometimes the screw will look perfect and it goes just to the tip of the vertebral body. If I see that and it even, touches it, I won't cement augment that screw just because I'm worried about any cement coming out anteriorly to it. And the reason for this is obviously, especially in our metastatic tumor population, these patients are oftentimes immobile, they have cancer, they're much more prone to pulmonary emboli, et cetera. And I have seen a case of, in one of my patients, of a pulmonary cement embolus coming from the cement augmentation. And so after that happened, if you go and you kind of look in the literature, there's not as much literature from spine vertebral augmentation, cement augmentation, but there is from kind of vertebroplasty in the interventional radiology world. And there's some data that shows that maybe up to 30 or 40% of our patients may actually have asymptomatic tiny cement emboli after vertebroplasties. So what are the things that we can do to try to prevent that? So I use the highest viscosity cement that we have available. I inject small amounts. So basically the smallest, lower amounts of cement have been correlated with less likelihood of causing these cement pulmonary emboli. And then also very slow injection. So after I have verified perfect placement of the screws on an O-arm, I am wearing lead in the operating room. I use constant fluoroscopy. I inject 1 cc of a very high viscous cement, and I do it slowly with my rep actually counting to make sure that I do that 1 cc over greater than 60 seconds. Usually, quite frankly, it ends up being up to about 2 minutes. For my technique. And so you can see here, very similar to some of the x-rays that Chris showed us, but you can see these nice little clouds of cement augmentation. And this is another metastatic cancer patient who was treated this way. So I wanted to share another case, which is a little bit different, because this is not a patient who presented with an acute neurologic deficit, where it's clear that that patient needed to go emergently to the operating room. So this is actually a different patient who I followed for a long period of time, and she was referred to me by one of our gynecological surgeons at Stanford. So 80 years old with stage 3C1 clear cell endometrial cancer. She's had a robotic hysterectomy. She's had chemoradiation, and she's had this C4 pathologic fracture. She's also pretty sick. She has had a recent pulmonary embolism, multifocal metastatic disease. She's been hospitalized recently for dehydration. She says that, this neck pain has been going on for a very long period of time now, a couple of years. It radiates into her biceps, into her forearms. When the pain's severe, she can't even lift up her arms. And at this point, it's really interfering with her quality of life. You can see she doesn't have a significant amount of spinal cord compression, and she has this, she also has overall degenerative spine disease, as one would expect in an 80-year-old, okay? So what should we do in a case like this, right? Her SIN score is borderline. She is a poor surgical candidate given her overall metastatic disease, her age, her frail appearance, her poor bone quality, and she basically just has mechanical neck pain, okay? So this is actually a patient that I treated for a long period of time in a collar. Okay. And she continued with her systemic therapy. She actually started to look a lot better from a medical perspective, but then she started to get worsening of her deformity and progressive neck pain. And finally, she said, I really just can't live with this pain. So after a year, we did end up taking her to the operating room and doing an anterior corpectomy and then posterior stabilization. Okay. And so this case was actually done open. And that's because we can do this very, very quickly and very effectively with this machine vision navigation technology that I also use in my practice. This is called 7D. So this uses similar technology as to what you have in self-driving cars. Okay, so most of us are probably familiar with, for example, the stealth navigation system from Medtronic, and many other companies have CT-guided navigation platforms where you need to get some type of intraoperative CT scan in order to, or at least fluoroscopy to merge that with the preoperative scan in order to use your navigation. So the difference here with 7D is that you have a preoperative CT scan, and then this light from 7D is actually a bunch of cameras that are taking an image of your field, okay? And then it takes that actual image and it uses that to co-register with your preoperative CT scan. So I'll take you through it really quickly. You position the patient, you need to approximate your level. Here you're doing an open exposure, and it needs to be a meticulous and open exposure. You place your spinous process clamp very similarly to your region of interest. And so now, instead of bringing in your intraoperative CT scanner, you bring in your 7D machine over the field, you take out all of your other lights, you get a very quick image of this, and this is called the flash registration. You want to see nice light around the part of your spine that you can visualize very well without blood, without soft tissue. Then you select points that are in your that are in your area of interest. And then you use that in order to co-localize with the preoperative CT scan. And so here, all of these green spots are, at this particular case, is a very nice registration. Of course, I'm showing you a good one that has like thousands of points that have co-localized. So now it allows you to, just like any other navigation platform, use a navigated probe to determine your screw entry point. You can do a navigated power drill and a tap, and then you can place a screw of any system using this virtual K-wire that they have here. So as some of the differences with the with other CT guided navigation platforms. So honestly, I feel like this is really quite good for open cases, okay, where large open decompressions are needed. You do have to do more of a meticulous bony exposure, so you need to be a little bit wary. I have done this sometimes in some cancer cases, and if you know that you are going to get into any cancer tissue in the posterior elements, then this navigation system is not the way to go, okay? Because if you need to stay out of the way of these tumor that's in the posterior elements, you can get into bleeding or get into tumor, and you're not going to get a good registration with this. So that is really an important thing to keep in mind, specifically when thinking about whether you're going to use 7D or another type of CT-guided navigation in your cancer cases. But I love that we don't have to get an intraoperative O-arm spin, so that decreases OR time. It's really easy to get a repeat registration. You just get, it takes a couple seconds to take a new picture of the field instead of bringing in your O-arm if you have any issues with your clamp moving. It does, similarly to other types of navigation, increases your intraop radiation exposure. We haven't talked at all about carbon fiber, and we could do an entire talk just on this alone, but I have started to use these very routinely in my practice now. So carbon fiber screws obviously are nice. There's two different kinds, and I'll show you sort of the differences. This is the one that we do have on our formulary so that I can use at Stanford, but you can see it on a CT scan, okay? So because there is a tiny amount of metal in this particular one that's around the threads, so you can see the placement of the screws here. You can still evaluate that effectively. And they're definitely a bit harder to see on an X-ray. Our residents call them the ghost screws, but you can see them here. So of course it's difficult to see if there's loosening or to exactly evaluate their location on an X-ray, but you can on a CT scan. And then here, the real advantage of using these is that they have significantly decreased artifact on the postoperative MRI. So our radiation oncologists are not necessarily needing to get the CT myelograms, and they can do their plans for the postoperative radiation with the MRI. And you can see here what the postoperative MRI looks like for a patient that's had these carbon fiber screws for one of our cancer cases. And they are very expensive. So I have started to do hybrid constructs. So you can see here what that looks like. So not only are they very expensive, but also the screw heads themselves are much larger, and they're more finicky and harder to maneuver. So I will place the carbon fiber more expensive screws closer to the area of the tumor that's going to get radiated, where the artifact really matters. And then I'll place regular titanium screws further away. And so you can see what this hybrid construct looks like. And these are carbon fiber rods that are placed through And another thing to think about, not only are these screws a little bit harder to use and maneuver, but also you cannot bend these rods. So you can't necessarily do like a 12-level rod. This is pretty impressive. We were able to do 1, 2, 3, 4, 5, 6, 7 level with the rod and not bending it. So it has to fit completely perfectly. And you can see here the difference on the MRI between the artifact for the carbon fiber screw versus a standard titanium screw. And these are just a few MRIs from our patient. This particular patient, you can see the different levels. There are 2 different types of carbon fiber screws if you're considering bringing them into your institution. So as I mentioned, the one that I showed you images of has a little bit of metal around the screw head and not around the screw itself, the threads of the screw, but not in the screw head or the rod. And there's another one that's available that has a little bit of metal in the screw head, but not in the screw itself and not in the rod. So you can see on the top the X-ray from the one that we've been using, and then you can see at the bottom that you see a little bit of the radio opacity at the head of the screw for the other one that's available. And it too has very nice profiles in terms of postoperative metal artifact. Last but not least, our expandable corpectomy cages. I think these are a great technical adjunct for our tumor cases when we're needing to do more work, okay, not necessarily a pure separation surgery, but if you have, so patient here, this is a metastatic angiosarcoma of the breast with some ventral compression in the cervical spinal cord. So you can see here, a titanium expandable cage is a great option. A vertebrum planum situation with severe cord compression, this in a setting of multiple myeloma, also a great option. And, we do have both PEEK as well as metal options for these expandable cages. I do like to get, if I am doing these cages for metastatic cancer, because I know these patients are oftentimes going to have poor bone, have had radiation before or after surgery, I like to use cages that have good spikes that can really get into the bone. And then I haven't used these yet, but this is an exciting new option of these carbon fiber expandable corpectomy cages as well. So in conclusion, the most important aspect of metastatic spine tumor surgery is determining whether spine surgery is even indicated and appropriate for this patient, right? My personal principle is to do the least invasive surgery possible for frail cancer patients. And percutaneous fixation with decompression and separation surgery is a big mainstay of this. Navigation is the standard of care in my practice, either more routine navigation platforms like Stealth for minimally invasive cases, or I oftentimes use machine vision for an open case. But as I mentioned, for an open tumor case, if there's a lot of posterior cancer, that may actually still be much better done with a Stealth navigation. And then really important adjuncts include cement augmentation, carbon fiber screws, and expandable corpectomy cages. So thank you again for this invitation. Here's my email, my cell phone. I am available on WhatsApp. And for anyone who's going to be joining us in spine section next week, I would love the opportunity to meet you. And thank you again to WFNS for this opportunity.
Thank you so much for your last presentation of this first part of this beautiful session of spine metastasis. Good presentation, very huge, very comprehensive. I should ask you a question and make a comment. The question is, why didn't speak about neuromonitoring, which is mandatory in order both to check the roots by intraoperative electromyography and long tract sways with motor evoked potential, mainly in unstable, virtually unstable metastatic spine. I think that should be strongly indicated. And second comment is about vertebroplasty and cement augmentation. Correctly, you suggest fenestrated screws. Otherwise, you know that fenestrateds are more weak compared to the classic strong screws. And in my experience, I prefer to put cement first through the pedicular hole and immediately after to put the screw. What's your experience about this option? But first, what about the neuromonitoring?
Yeah. So I didn't speak about it, but I use neuromonitoring routinely in almost all of my spine surgeries. So across the board, whether it's tumor or not. So if it's I use it for all of my cervical surgeries, pretty much regardless, anterior and posterior. And I would use it for any of these cases as well. I mean, I even use it in a posterior L4 to S1 decompression infusion. So it's pretty much standard of care at our hospital. So would definitely use it. And then great point about the different ways of doing the cement augmentation. So actually, yes, in my training, So I trained at UCSF, and I worked a lot with Chris Ames, who's one of our deformity surgeons. And the way that you described the cement augmentation is actually the way that that he did the cement augmentation for the deformity cases. So basically at the UIV, the upper instrumented level, and the upper instrumented level +1, what we would do is we would put in our screws at the upper instrumented vertebral level. We would just put in a pedicle marker. We would obtain an O-arm spin, assuming it looked perfect, inject the cement, and then put it in. And I did, I think when I was his resident, we looked at a paper which we published showing that technique was safe after we had gotten the intraoperative O-arm confirmation. So I think it is, obviously a very valid way of doing it as well. So yeah, I think there's a lot of different approaches, but yes, we did do that. And I know we have actually published a paper on it showing that it works well. This is the way that I have been doing it in my practice, and in particular for the tumor patients.
Yeah.
Thanks.
Dear Massimiliano, I think we should finish that session. I thank all the speakers because we have time constraints. We exceeded the time.
Okay, thank you. Thank you.
If you want to comment on some points, then we can start the second session.
No, I'll request the speakers to answer in the chat box so that we can go on to the second question. We can go on to the second session.
Yeah.
Yeah. I'd like to thank all the speakers for giving a very good. Yeah.
I also thank all the speakers for their very valuable lectures on metastatic spine tumors. Now, as the WFNS Education Committee, we will start a new type of lectures, tricks from the masters. First time, I'm very proud of having Dr. Robert Spetzler with us, and I will tell a few things about his CV. He's one of the world-renowned neurosurgeon who has specialized in cerebrovascular disease and skull-based tumors. And he has been involved in pioneering the technique of hypothermia and cardiac arrest for the treatment of difficult brain lesions. He was born in Germany, and he has moved to United States at the age of 11. And he has finished the Northwestern Medical School in Chicago, and he has graduated training in Wesley Memorial Hospital in Northwestern in Chicago. He completed his residency in neurosurgery at the University of California, San Francisco, and received board certification in 1979. And he has received many awards from different societies and different countries. And he has published more than 300 articles and 180 book chapters. And he's the co-editor of the Color Atlas of Microneurosurgery. I will moderate the session with my dear friend Alvaro Camparo, and we will have 3 young neurosurgeons who will ask questions about how to proceed in their career in the future. Yes, please, Professor Spetzler, you can start your talk.
Can you hear me okay?
Yes.
Yeah. Mehmet, thank you for that very kind introduction. It is a privilege to address especially the young neurosurgeons, to hopefully pass on some of the experience often obtained by making mistakes so that they don't have to repeat the same mistakes. And so I'm going to share sort of what I have learned and some tricks and lessons. And I'm going to use as my substrate cavernous malformations because they respect no boundaries and they challenge us many times in how we get to certain parts of the brain, especially deep parts of the brain. I have greatly enjoyed working with cavernous malformations, and they have taught me an enormous amount. What are my general recommendations? I think we need to start off a little bit philosophically, and that is to have mentors, people that you look up to, that you copy, you observe, you study, you remain open to what others think and learn from them. There are many roads to Rome. You have to choose the one that works best for you. Details matter, and I'll spend a little time on that. And then very important is that when our residents or fellows leave the nest, I emphasize to them, start with easy cases. Do well with those cases, and your reputation will grow, and you will not start off with a disaster that will haunt you for a long period of time. Progress slowly. Be confident enough to stop. By that I mean is when you are looking inside the brain and you see that you're not going to be able to finish this successfully, stop and back out. It takes a lot of ego to tell the patient, I'm sorry I wasn't able to finish this, but your health is much more important to me than finishing something that I thought might hurt you. And then finally, enjoy this incredible privilege that we have been entrusted by patients to take care of them. So I had my own 3 professional mentors that I tried to emulate. My boss, my chairman, Dr. Wilson, who was dedicated, focused, was an incredibly hard worker. Ghazi Yassergil, who was a surgical virtuosity. He trained a whole generation of neurosurgeons. And then finally, Charles Strake, who many of our young colleagues will not remember, but he was a giant in neurosurgery. He did more basilar artery aneurysm than anybody else. But what I considered for him as a mentor is that you could approach him. You could be a medical student and you could sit next to Charlie and have a conversation. And I absolutely loved that about him. So what did I learn from him, mentors? Well, you have to have a passion for your art. You have to have self-control. You have to be a team player. You can't be solo anymore in today's world. And you need to be a mentor. Being a mentor, you also learn a great deal. And I think if you want to be in academics, you have to read, not only read, but you also have to publish and you have to present. And most important is you have to learn from mistakes. When we have morbidity and mortality conference, the most important thing is not to point a finger and make somebody making a mistake, but actually learning from that so we don't repeat it. Share success, own failure. Mentorship and technical excellence, we need to practice, practice, practice. And today you have courses, you have online courses like this, and you have cadaver courses, you have technical courses. You can practice experimental bypass with very little material. You can travel and observe, copy what works for you, and reject what doesn't. Be a team player, very important. And then analyze each case before you start and be prepared for all points of failure. I can't tell you how many nights I was not able to sleep because I was doing a big case the next day, and I would go through it and I'd see this mistake that I could make or this mistake. And by that, you are sort of prepared when something bad happens, what you're going to do next and contribute and be a mentor. Everybody has their own way of doing it technically. And I can tell you that for me, I like the sitting position. I like the armrests. Let me just use this here so you can see. And I like the foot pedals that give you additional control for the microscope. Personally, I need to have a mouthpiece so that I can move the microscope all the times. Details matter. I just mentioned a few of them. Position for the patient and the surgeon. The patient has to be positioned properly so you're not compressing any veins. The surgeon has to be comfortable enough so that if it's a long case, you have no trouble performing it. All of these are important, and all of them play a role. Retractorless surgery. We've published a lot on that, and it's not a new concept. My point is that when you start an operation, don't just automatically place rigid retractors, but rather use what I call dynamic retraction, where you use your instrument to mobilize your exposure. If you think that retraction doesn't do anything to the brain, I want you to look at this little video. Nothing is done except to hold the dentate ligament upsliding. Notice how there is no blood flow underneath that tiny little bit of tension. And when you release it, it comes right back. The brain is very, very sensitive to compression. Approaches. Well, I've said it 1,000 times, exposure is everything. If you get there, if you can see it, then you can take care of the problem. For cavernous malformations, we've learned that you have to present the venous anomaly. One of the first cases I ever published, I took this large vein in association with a cavernous malformation in the posterior fossa. Patient did fine for a few hours, and then that had a massive venous infarct because we didn't realize the importance of it. That mistake should never, ever happen again. Image guidance is important, monitoring, sharp dissection, burst suppression, anatomy, 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 and as I mentioned, avoid rigid retraction. We don't have time to spend a lot of time on anatomy, but I can tell you that what makes Yasirgil a spectacular surgeon is because he knows his anatomy intimately. When he looks at the surface, he already knows what's underneath. We have a lot of tools these days that can help us with that. And if you just think of lesions in the same portion of the brain, even though they're very close physically, they have totally different approaches. We've published on the thalamus, and we've divided into 6 separate regions, each region requiring a different approach to get there. And they're sort of summarized here. I won't spend any time on that, but I will show you some cases. We have now, with intraoperative image guidance and our incredible magnification, we can go to anywhere in the brain. And so we want to avoid retraction. We want to use ICG wherever necessary, and we want to pick the right approach. Oops. Oh, here we go. So we want to avoid retraction. So this is sort of the setup that I like. So we have image guidance, we have the microscope, we bring it in, and then we've added on lighted instruments. When you are going down a very narrow channel, you lose light because the light comes in at a different angle than your visual line of sight. And it depends on how far down you go as to the angle. It goes between 3 to 6 degrees. And so by adding light, you can see beautifully even in a very small corridor. So we analyze each case. So we look at this particular cavernous malformation, and we have to decide which approach to use. Retrosigmoid, not unreasonable. OZ, S supracerebellar infratentorial midline, lateral, Kawase. And for this particular case, if you look at this angle, a lateral supracerebellar infratentorial approach is really the best. The tentorium is a beautiful structure because it gives us so many different angles to get to the deep portion of the brain. All we need is a small opening. Tentorium is up here. No rigid retraction is in place. Patient is not in the sitting position. We get down to the ambient cistern. We open, let out a little bit CSF. We just take our time until we see our pathology. And then we just take out the cavernous malformation piecemeal. And this is no rigid retraction in place. Patient is sort of a lateral, angled position with the head flexed, and we take out the lesion. And it comes out very readily. So decision-making, here's a medical student with a sudden onset of severe headache, apoplectic event, and she has this MRI scan. Now, what is most important is when we look at this is obviously very, very close to the fornix. Great respect for the fornix, and we need to preserve the fornix. She has excellent functional memory. So the first question we have to ask ourselves, do we observe this patient or do we offer surgery? If surgery, what approach? Interhemispheric? Lamina terminalis? If interhemispheric, what position? Straight up, which is the classic way, or lateral? I like lateral because you have many advantages. Our eyes are horizontal, our hands are horizontal, and gravity will pull down the exposed hemisphere. So there are many reasons to go lateral. Here she is in the position, and then I use the table to make it completely lateral by angling it. Image guidance brings us right down to the lesion. Very straightforward. I won't spend a lot of time on this. And we take it out and we close. Just a little straight incision. The lesion is completely gone. Her exam is normal. She goes back to medical school a few days later. What about this one? You have this cavernous malformation. It has bled several times. You see it where it lies in the frontal horn. First thing we have to do is ask what approach. Transfrontal, perfectly reasonable on the right side. Interhemispheric transcallosal, difficult because you have to make this corner. Or contralateral, interhemispheric, through the cingulate gyrus, a direct approach. And that's the one we chose. So what we're going to do is we're going to put the patient lateral. We're going to identify where we need to make our opening in the falx. And so here's the lesion. Here's the exposure. Contralateral hemisphere is dependent. No rigid retractor in place. We use image guidance to decide where we have to make an opening in the falx. We make that opening. Make a little opening in the cingulate gyrus, very small. And we go right down to the ventricle. Beauty of image guidance, naturally. We just follow the track. And there's our little cavernous malformation, which has caused this individual all sorts of harm. And then all we have to do is separate it, get all the little veins that are part of the lesion. And then take it out. And it comes out very readily. And here we are all the way across. And we take it out. I want to be sure we don't lose it in the ventricle. And there it is. Very small opening. And that's how we went. For the spine, for the spinal cord and the medulla, it is also important to remember what we are capable of. We have basically three approaches in mind. The midline myelotomy, the one through the substantia gelatinosa or dorsal root entry zone, and then lateral between the nerve roots. So those are the three approaches. And just like in the medulla, the anatomy for the spinal cord gives you those three approaches: the lateral, the dorsal, and the midline. So here's a classic midline one. This was a familial case. They both had lesions in the same place. The son had a hemorrhage from his lesion. This is the father, but a hemorrhage from here, and he was in a wheelchair, a terrific person. But his dad, who had this exact same lesion, 6 weeks after this happened to his son, he insisted his come out, and that's what comes out. A little more challenging is the one that's off to the side. Patient also with arm pain. So here we are. Here's the dorsal nerve root. We make a little incision right along it. We get right down to the lesion. You notice just gentle retraction with your forceps. We identify the cavernous malformation, and we take it out in a piecemeal fashion. Even more challenging is this gentleman who went all over the world, had several hemorrhages, and here's this cavernous malformation. You can see that this time it's much farther anterior. So this time we're going between the nerve root. Here's the dorsal nerve root. Here's the dentate ligament right here. And so now we're going directly to the cavernous malformation. And you can see by when we pull it out, the different consistencies that represent the different ages of the hemorrhages. And then I always use a little counter pressure. This is a sucker. When you take your finger off, there's absolutely no suction. So you can regulate it very closely. And here's the post-op. You see the lesion gone. Far lateral. This is a very short course to really be talking about the intricacies of these approaches. But with far lateral, you really have different degrees of exposure depending on how much of the condyle you remove to get there. And so you have to decide again which tracks you're going to go in between in order to get to your lesion. So I'll just show you one. This is actually a reporter or an editor of the London Times, and she had this lesion that bled 3 times. And through a very small paramedian incision, we get directly to this angle. And you can see the vein that's associated with the cavernous malformation. We're in front of the medulla. You can look at the different colorations, the fluorescent orange and stuff, all different ages of bleeding. And because of this exposure, you require absolutely no retraction, no rigid retraction, and you remove the lesion. And then she wrote a book about an experience, which I recommend. It's on Amazon only, so we're reminded of what the patient experiences. We tend to go from one patient to the next and don't give enough time to what they go through. Suboccipital approach, I personally like to have the patient in the prone position. And just to remind yourselves, when you have a lesion in the base of the floor of the 4th ventricle and the patient is asymptomatic, that is not a surgical lesion. Here's one where the patient was very symptomatic, straightforward, came out very easily. I'm not going to spend any time on that. More interesting are the ones that are off to the side. That's the post-op here. Neurologically unchanged, but the patient already had a preoperative deficit. So this is more interesting. This is a cavernous malformation that's off to the side along the foramen of Luschka. So we're going to do a telovelar approach. And telovelar approach, this is the position. The anatomy is just incredible. And we just have to know this anatomy to know what we are capable of. So that's why the fourth ventricle floor is so difficult. But when we get off to the side, to the foramen of Luschke, we are talking about the middle cerebellar peduncle, which is very robust to incisions. So here's a pica coming up, feet are up here, head is down here, fourth ventricle. Put a little bit of gel foam in here to prevent any blood from going into the aqueduct. And then we just keep going lateral. Here's the gel foam going in. We just keep going lateral until with image guidance, and you'll see the white of the floor of the Luschke, because it's obviously white fibers. We just mobilize, and there is the foramen Luschke, right there, that white. Then with image guidance, once I've identified the direction I want to do, I make a very small opening. There we are, very small instruments, pituitary-like, but just micro. This is just millimeters opening. And we take the lesion out, comes out very nicely. Here's a little debris left behind, but it's gone. This one, I just want to demonstrate a very important point. I think here's a patient with familial cavernous malformations, multiple cavernous malformation. Here's the lesion. Still has hearing in this ear. So what we want to do is we want to operate through a retrosigmoid approach, but we want to have our trajectory so it goes right through the middle of the cavernous malformation. Why the middle? Because we have equidistance then to the base and the top. This top, if we come in just here, is a long reach and we're going to hurt the brainstem. I can't overemphasize that point, going through the middle, and once you're at the end, you know we're at the end with image guidance. So here it is, fifth nerve. We go up on the brainstem until we get that trajectory I showed. This is the brainstem where the fifth enters. We make our opening, and this is a cavernous malformation that's very large, so we just keep taking it out and out. Make this opening. And we just keep taking it out until it's out. And here you can see the post-op, that's the hole. But most important, the hearing was preserved. This I include because I want to make a good point here. The key is the middle cerebellar peduncle, as I've mentioned before. So to get to this lesion, we want to open the petrosal fissure. Again, the patient is just in a lateral position, sort of a concord. You saw the lane of the Dandy's vein over here. I never take it. It's a very nice reminder never to over-retract. We have the lower cranial nerves, and then we open the petrosal fissure. It's just like the Sylvian fissure, except it's more fragile. So you have to be very careful to separate the cerebellar hemispheres. And then what we're exposing is as we go between the cerebellar lobules, we expose the middle cerebellar peduncle. And here we go. We just keep going very gently, spreading the two hemispheres, opening the arachnoid plane that exists there. And now we're seeing the middle cerebellar peduncle. And then with image guidance, we know where to make our incision, make a little opening. And I really just wanted to show you that. And notice, no retractors in place. No retractors. And this is not the sitting position. And we take it out. And there's left a little air behind. This here is pretty straightforward. And I just want to remind yourself of the anatomy. Here we have a cavernous malformation below the medial lemniscus, cerebellum, temporal lobe. Tentorium sits right here. So this is no doubt what we want to do. So we want to use the tentorium, and we want to decide the angle. In this particular case, we're going to do the lateral angle because we want to get right here. And so here we make this little opening. We get down, let some CSF out. You notice the angle that we're coming in off. Look how far lateral we are. And then we get to the cavernous malformation. And not much to it. We take it out. Here you can see where we entered, way off to the side, and there's the empty cavity. What are the limits? Well, here's one that had been operated on previously somewhere else from a subtemporal approach. Patient was in a wheelchair, had more hemorrhages, and so we're going to use the same approach. This time we're going to have to open the tentorium because the lesion extends toward the foramen of Monroe. So we open it, and as long as we stay extra-arachnoid, we know that we're not going to injure the fourth nerve, which just lies just below the arachnoid. And then we make an opening in the medial lemniscus, and we get right to the cavernous malformation and take it out. There it is. And again, my point is to show you the approach, not taking it out. And there's the post-op. Lesion is gone. And then I get a report from his neurosurgeon that referred him, and he's now able to ambulate independently with much better balance. Well, here's the largest one like this I've taken out. It's a young woman from Europe. And you can see where it sits all the way up to the foramen of Monroe. And the question is, can we take it out? So we do again the same thing. We're going to go cut the tentorium and then take it piecemeal. But notice the angle. We're coming right through the middle of the lesion. We can just follow it right up to its extent, and we take it out. Now we're all the way to the end. This is what it looks like post-op. And she goes back home. How do we get here? This is a lesion in the roof of the third ventricle. And there are different approaches. I think everybody would go interhemispheric. I like to go lateral to the choroid plexus. So then we go through the corpus callosum. We see the foramen of Monroe, the choroid plexus, but I like to go lateral. The books tend to write medial. The trouble is medial to the choroid plexus is where the fornix is, and I like that extra protection. Having the fornix, and I just use my sucker to retract it over. We identify the lesion, which is just below it. And in this particular case, I use a little CO2 laser to separate it from the internal cerebral veins, and it comes out very nicely. And this is what it looks like afterwards. Gone. More difficult now is this young man who's got a cavernous malformation that's sitting right at the end of the third ventricle into the aqueduct. So the exposure is exactly the same. So now we're going into the third ventricle. Here I need a rigid retractor because I need to hold over the corpus callosum that is hanging over. We are looking at the entrance of the aqueduct from the third ventricle. We take very tiny pieces in a piecemeal fashion until it's completely out. It's sort of nice because we could see the CSF then coming up from below. And it comes out very nicely. And there it is, pre-op, post-op. Pre-op, post-op, completely gone. And finally, the largest lesion that I've seen like this is in this young 6-year-old who had sudden deterioration, was operated on in his home country for 16 hours, severe blood loss, no diagnosis. They attempted embolization in Houston and also had to back out because of extensive blood loss. This is a cavernous malformation of the transverse sinus. Lesions inside the vascular sinuses are like AVMs. They are very, very bloody, very, very vascular, and have to be treated totally differently. When they are small, they are very sensitive to radiation, totally different than the rest of the cavernous malformation. So this is what it looked like. And my colleague, Dr. Albuquerque, you notice that the sinus is occluded from the lesion. He found one little vessel to enter it through an external branch and put all of this onyx into the lesion. That just shows you how vascular it was. When I operated, I made the craniotomy bigger. I cut the tent and the sinus on both sides. And then all we had left was this giant tumor, which was very easy to remove. Because of the onyx, you can see the sparking when I'm using the cautery, a tool I rarely ever use inside the brain. But for this year, it was just ideal, and we take it out completely. And there he is after surgery with his beautiful mother. Here's the post-op. And then I was very disappointed that she kissed him instead of me, who did all the work. But I have a nice follow-up from him. 1-year follow-up. He's the best in his football team, which is soccer, and a very good student. And then I have a 9-year follow-up. This is his original lesion. This is 9 years later. Excellent student and soccer player. And with his permission, that's a picture of him. So what have we learned? Well, we've learned how to get to these places in a safe manner with acceptable morbidity and mortality. We made many mistakes, and they have taught us where not to go. So of great importance is knowing how you can get to these areas in a safe manner. And I don't think there's any place in the brain anymore that we can't get to. We've shared this in 2 volumes with videos in each one of those. Also, the Neurosurgery Journal has a classic collection of all my videos, which are available to anybody. So in conclusion, have mentors, learn the anatomy, learn this art, and I like a double pause. We know the first pause before we start, we want to make sure that the patient is oriented appropriately, that everybody's on board, the nurse, the anesthesiologist, the surgeon, the resident. The second pause is at the end of the procedure. I recommend looking at what you have done, determining whether you needed that much exposure or whether you needed more exposure, and then apply those lessons that you learned from the case to the next one. Details matter. I've emphasized that. I want to emphasize to start with easy cases. Exposure is everything. Progress slowly. Be confident enough to stop and enjoy this incredible privilege that patients entrust themselves to you. And don't forget to enjoy life. And that's me enjoying life. Wine country, bicycle trips, sailing, crossed the Grand Canyon 34 times, heli skiing, bike riding. I've never stopped enjoying life. And I think it's a nice combination, this incredible art that we practice called neurosurgery and the ability to make a difference in so many people's lives. I thank you very much for your attention.
Yeah. Thanks a lot. It was a great talk, really. Probably Dr. Alvaro can moderate the rest of the session. Alvaro, do you want to say something?
Yes, thank you very much, Dr. Spetzler, for this outstanding lecture. I would like to ask to the young neurosurgeon to do some commentary or question. Please, Matthias.
Hello, Professor Spetzler, Professor Sileli, and Alvaro. It's a huge pleasure to listen and to attend your presentation. As you are really a huge master for all neurosurgeons, especially for young neurosurgeons. Your expertise and dedication in neurosurgery continuing to inspire countless generation of neurosurgeons worldwide, and your legacy you have built is a really a huge example for us, and serve as a guiding light for young neurosurgeons. And I would be really honored to ask you a question. An
I'm afraid you're breaking up.
intelligence and virtual reality. How do you see its role evolving? Are you listening to me?
Yeah,
Matthias,
but
your
Can you
internet
listen to me,
is
Professor?
not good.
yeah, you're
Okay.
breaking up.
It's okay now?
Yeah. Hi, Hero.
Okay. Can I ask you a
Yes.
question now? You listen to me. Sorry. As my reality continues to advance in medicine and in neurosurgery, how do you see its role
Matthias, we cannot
evolving in
listen well.
surgery,
Okay.
particularly in
I think he wanna ask the artificial intelligence, the
Oh,
value of artificial intelligence in our practice.
and
yeah.
surgical
You know,
planning for complex.
I'm just reading the book Nexus, which talks about artificial intelligence in a very, very
Sorry.
great.
Now,
Can you hear me? I think AI is going to make a big difference in medicine. There's no doubt in my mind it's going to help us make decisions much, much better with endless memory, etc. The real question is, will it also have a downside for politics, which we won't be able to handle?
Thank you so much, Dr. Spetzler. Dr. Dugrel, would you like to do some commentary or question, please?
Thank you very much, Professor Campero. Professor Spetzler, it was a great presentation. Thank you so much. You mentioned in your presentation, as I understand, one of the most important thing is you said 3 times anatomy, like Professor Yaşargil. And I would like to ask you that what role should cadaveric simulations, virtual reality, or other training modalities play a role in enhancing these technical skills before a real case exposure? And considering the increasing difficulties in obtaining cadaveric training, do you consider these modalities can replace cadaveric training, or should they be used like a complementary in neurosurgical education?
I think it's really a very good point. Right now, I think it's complementary, but in other places, like in our own shop, we are very close to having a beautiful 3D model that really has detailed anatomy in it. And there's no doubt in my mind that cadaveric workshops are going to disappear as this becomes better and better. And the fact that it's endless, it will probably be very personal, so it's available to you all the time. It'll be a great additional tool.
Thank you.
You're welcome.
Thank you very much. Is another question, Matthias or Dr. Dugrel?
I can have another question also. Professor Spetzler, you have trained and mentored many neurosurgeons over the years, and you were a teacher of many of neurosurgeons. As we are junior neurosurgeons who are targeting to get the excellence in neurosurgery, what qualities, skills, or attributes do you consider most important in a trainee? How do you identify the potential for excellence in neurosurgical training?
So I can tell you that I think the first thing for a specialty like ours is you have to have passion for it. And by passion, I mean you're going to give it your all in order to get to be the best you can be. The other thing you have to do is I think you have to be compassionate. We have never accepted a resident applicant in our shop if a secretary or a nurse or technician said that when they came for an interview that they were treated with less than absolute great respect. I think if somebody feels superior to a secretary, they're not going to make a good neurosurgeon. Our specialty gives you incredible highs. Unfortunately, it also brings you very, very big lows. And when you have been involved in a case that has not gone well, it weighs heavily on you, and it should. And from that, you should learn.
Thank you.
Thank you. Dr. Spetzler, I would like to do a question. Do you believe that surgery as we know it today will disappear in the near future or not?
I wouldn't say the near future, but I think, endovascular advances have taken over a lot of the simple cases of aneurysms, so that the surgeon right now the microsurgeon is really confronted with the more difficult ones, the ones that require a bypass, etc. I have a whole talk on aneurysm. I didn't choose that because cavernous malformations are so nice in their anatomical distribution. But the same thing with aneurysms. There are those that you approach and those that you treat surgically, those that you treat endovascular. I think surgery is going to get better and better, but it's going to be at least another generation, another possibly 2 generations before the actual practice of surgery will disappear.
Thank you. Dr. Sileli?
There are many questions actually. The one that is telling Dr. Gabriel Vargas saying that endovascular training, we are thinking about it, and if the hybrid training good, if we have to be a candidate for hybrid training, endovascular and microsurgery.
I have trained quite a few fellows and residents who have become hybrid surgeons so that they do both the microsurgery and the endovascular. My personal feeling is if you really want to make a difference to one of those 2 specialties, you have to concentrate. They're very different in the instrumentation that's required, in the technology, and how to get there. And it's like anything else. If you want to super specialize and really make a contribution, you have to just concentrate on one or the other. But in many places where you're not going to be trying to push the envelope, being a hybrid neurosurgeon, I think is just fine.
What about changing our training technique in the future? Shall we change it in a different way, like using simulation methods and some other techniques instead of the current training techniques?
No, I think training is changing constantly. I mean, you already have the means to do endovascular practice in simulation that is very close to what you do in an actual patient, and you can hone your skills way before you ever put a catheter in a patient. We have so many tools now in the laboratory for training the aspiring young neurosurgeon, which were never available when I was training. So I think it changes all the time, and your job and my job is to allow this to happen and encourage what is good and discourage what we don't think is very good.
Yeah. The importance of the anatomy is very, very big. And Alvaro is one of the pioneers in teaching anatomy. What do you think about this, Alvaro? You have certain questions to
Oh, yes,
Professor Spetzler?
of course, like Dr. Spetzler said, the anatomy is a very important part of the surgery. The difficulties in all the world is to get cadaver. It is very difficult, at least in Latin America, and it's so difficult to have a laboratory with a all head. Maybe you can have a brain or temporal bone and something like that, but not the whole head. So this is a big problem in all around the world. In US, not problem because you can buy a head and something like that, but at least in Latin America, it is impossible to do that. So that is a problem, I mean, for the neurosurgery.
I mean, that's why simulation is going to be so important.
Yes, that's right.
I mean, there are very good reasons why cadavers may not be available, whether it's for religious reasons or just feelings, culture, history, etc. So I think the new simulations, the new models that are being created are so good that it won't be long that they'll be just as good as a cadaver.
Thanks.
Do you have a simple conclusion sentence to be a master in neurosurgery for the young candidates of neurosurgery?
Yeah,
Do you have a simple comment?
Yeah. Practice and be humble. I mean, it's such an incredible privilege. Even today, the privilege of patients putting their lives into my hands is a responsibility, an awesome responsibility that we all have to take so seriously. And because of that, we have to strive to be the very best that we can be.
Dr. Sano, do you wish to make some comments on that?
Yeah,
Professor
hello.
Hi,
Robert.
Sano.
I'm glad to you are very good and Nancy also. And but by the way, that carcinoma is approaching with everything. I think so. When I was young, I went to the anatomy room and to get the brain and always check before the surgery and draw it, and then after the operation I check it again, and so I did 3 times before and direct and after checking.
So you want to do a 3 pause, not 2 pause.
3 pause, yes.
Okay, I like that.
Yes. Yeah, maybe the recently the young generation cases are very few. Our generation so much cases, but nowadays cases so few. Then they must mimic, simulate, mimic the Robert and me, and then you do yourself afterward. That is the point, probably.
Yeah.
Yeah.
Yeah, we have been friends for a very, very long time.
Yes.
Any other questions from Yücel and Matthias?
I can share one more question also. Professor Spetzler, how was your perspective on the role of open surgery evolved with the rise of the endoscopic surgery, endovascular interventions, and concept of minimal invasive techniques? How did they affect your perspective on open surgery?
Well, if I was going to show you the aneurysm talk, you could see the evolution of the openings. And then finally going through the eye, over the eye, these tiny little incisions. I think you have to sort of incorporate whatever works and whatever works best. I think when you look at endoscopic surgery, there is a curve where the enthusiasm ends up taking on cases that shouldn't be taken on. And then we pull back and we learn this is the best indication for that. But endoscopic surgery, endovascular surgery, they're all part of this armamentarium of the neurosurgeon. And I think the most important test is to be able to look in the mirror at night and say, what I offered my patient was the very best for that patient, for their problem. Then you can sleep.
Matthias?
Yes, Professor Spetzler, and I fully agree with you that one of the most important tools for neurosurgeon is the neuroanatomical study and neuroanatomical practice and microsurgical skills that it's important to get it in the laboratory. But another important thing for young neurosurgeons is to produce research papers. What's your advice, your suggestion for young neurosurgeons, especially in a time where to perform a research paper, sometimes invest a lot of time, and sometimes you are not able to reach the final publication due to a lot of rejections of the neurosurgical research articles. What's your suggestion for young neurosurgeons?
Yeah, I think we've all been there. I think in our residency program, you have a minimum of a year of research, and it can be clinical or it can be in the laboratory. And it includes also that you can go elsewhere. You don't have to be at home. I think one of the important parts of research is not that you necessarily have to produce something that is unique and will revolutionize the art of neurosurgery, but to appreciate what research offers, whether it's in basic science. So you can speak the language, because I think many of the advances that we've had in neurosurgery is a collaboration between the clinician scientist and the basic scientist. The basic scientist who can spend all of his or her time on a particular project, and the clinician scientist who defines the problem as it pertains to the patient population. So I think exposure to research is critical. I'm not so much interested in the huge flood of research papers that don't contain a lot. It's much better to be selective, but to be exposed to research as a resident, I think, is important.
Thanks.
We have some other members of the WFNS Spine the Education Committee. Sabino, are you here?
Yes, Mehmet. Can you hear me?
Yeah.
Sorry, it's some noise here.
Yeah.
Congratulations once again for this beautiful lecture. And, it's precious for us to listen to all these precious advices for Professor Spetzler, that is a giant. And my greetings to him and I cannot ask anything more compared to, my colleague, just consideration about anatomy. I totally fully agree with you, Jill, and it's beautiful. Thank you so much, and thank you once again for this beautiful opportunity.
Thank you, Sabina.
Thank you, Professor.
What about Roberto Leal? Would you like to tell something? He's not on the scene. Okay.
You're muted.
Microphone is out.
muted.
Sorry. I think we have to come to the end of that wonderful meeting. I appreciate the Professor Spetzler's time and very nice lecture, and also all the participants, all the discussers. Alvaro, would you like to tell something?
Just thank you very much again, Dr. Spetzler. Thank you.
Yeah. Thank you, Mehmet and Alvaro, for putting this on. I think this ability to communicate around the world is just spectacular. And
Yes.
I'm delighted to have been able to participate.
It was our pleasure. Thanks a lot.
See you soon,
Goodbye.
Professor. Goodbye.
Goodbye.
Bye.
Goodbye.